I'm Dr. Rehan Folarin, and it's my pleasure to welcome you once again to today's lecture on anatomy. And today we'll be delving into the anatomy of the lumbar plexus, and we'll explore its formation, its anatomical relations, its branches, its functions, and some clinical relevancies. So as we go along, as you're quite familiar with, we're going to be testing our understanding of what has been learned so far. So on that note, I'm glad to, as promised, give another series of shout outs to those amazing students who correctly answered the questions on gluteal and hip anatomy. So on that note, the very first answers were received from Hassana Barua. Congratulations, Hassana. She not only was the first person to drop her answers, but also got them all correctly. So I congratulate you for doing it yet again. And same goes to Abasi Freke Jackson. Congratulations, that was a very nice try. She got it all. Also, Moses 13, well done. You got all the answers correctly. And lastly, Abdulrazak Fatiha. She did it again. Congratulations. So I encourage you all to continue to engage, access this document early enough and make benefit from them. Give engaging comments. There was actually one thing left out, however, in a number of your responses. A number of you are yet to give your suggestions on mnemonics that would help to remember the muscles that are responsible for a number of movements at the hip joint. So beyond answering questions on the MCQs, I still expect mnemonics from you on those areas that have been mentioned, and it's going to be fun. I already dropped that of PGOGOQ, remember, amongst other muscles. So do the same for the abductors of the thigh, do the same for the adductors, for the flexors, the extensors, amongst others. And it's going to be very helpful in remembering some of these muscles. So well done. It's a learning process, and I'm sure you continue to have fun as we tag along. So today I have 10 MCQs spread throughout the lecture, and at the end of the lecture, as usual, I'll be expecting to see the first set of students who compile all the correct answers and drop them in the comment section. So let's see how that goes. Congratulations to you all who are following. It's going to be rewarding at the end. So today we have objectives to include the description of the formation and branches of the lumbar plexus. You should be able to explain the anatomical relationships and distribution of its branches. You should also be able to correlate the clinical importance of the lumbar plexus with common pathologies. So let's dive in. To set the background, a plexus or plexus is referred to networks of successive ventral rami that exchange fibers by way of crisscrossing, and redistributing around. Do you think this has something protective? The answer is definitely yes, because during the crisscrossing, it enables the nerves to have components of motor fibers within the sensory neurons, and you have sensory fibers in motor neurons. And that way, nerves are able to complement one another and also provide alternative whenever one is paralyzed, then the others will compensate for it. So this is something very protective. So plexuses mainly innervate limbs, right? And you'll observe that in this diagram, the spinal nerves in the cervical region, that the cervical spinal nerves, are here illustrated. The thoracic spinal nerves, the lumbar spinal nerves from L1 to L5, the sacral spinal nerves from S1 to S5, and the coccygeal nerve 1, right? So from these spinal nerves, you have plexuses forming, especially in the cervical, the brachial plexuses, okay, forming, and then you have the lumbar plexus and you have the sacral plexus forming from these spinal nerves. What you have in the thoracic region is the intercostal nerves, okay, as well as the subcostal nerve. So the thoracic ventral rami do not form nerve plexuses. That's why you don't have a thoracic plexus listed here amongst others. So to take a closer look, the cervical, the brachial, the lumbar, and the sacral plexuses are here illustrated. And let's appreciate this in the next picture and an enlarged version. So here you have the lumbar plexus, and you will notice that it is listed from L1 to L4. Okay, and let me quickly mention that I have also provided a second picture, a second perspective, which actually notes, it takes cognizance of the fact that once in a while, even though it's not always, you have contribution to this to the lumbar plexus the from the T12 nerve. And that's why you'll see in this picture, you have the lumbar plexus starting from T12 down to L4. But most cases, you have the L1 to L4 making up the lumbar plexus. And you will see the thoracic spinal nerves on the other side. You see the sacral plexus on this end, and you see the sciatic nerve, emerging uh, from from the combination of the sacral spinal nerves, emerging from the sacral foramen. So you also see that from this lumbar plexus, a number of nerves are emerging. So you have the picture on the left part of this study clearly emphasizing the spinal nerves, while their branches are emphasized on the right side. So from the L1, you'll see two nerves emerging. You can see the iliohypogastric nerve. Okay, we'll come to the function of each of these nerves subsequently. And you have another nerve, the ilioinguinal nerve. Okay, you also have the genitofemoral nerve. You have the femoral nerve itself, different from the genitofemoral nerve, which will end up branching into the genital and the femoral branches. So the femoral nerve proper is right here, and then you have the obturator nerve. There is also an accessory obturator nerve. You have the lateral cutaneous nerve emerging from this end. So we'll come down to each of these, but just to give a background on how each of these um, components of the lumbar plexus gives rise to different branches. So the lumbar plexus is a network of nerves that are located in the posterior abdominal wall, and it is formed by the anterior rami, okay, not the posterior, the anterior rami of the L1 to L4 spinal nerves. So the plexus is critical because it provides motor and sensory innervation to the lower abdomen. It provides this innervation to the pelvis and most of the lower limbs. So its position here it makes it very clinically significant, especially in surgeries and in certain nerve entrapment syndromes. So to speak more about how this plexus is formed, it is formed in the psoas major muscle. It's formed in the psoas major muscle, particularly posterior to this psoas major muscle. That's where the formation occurs. So when we say it's formed within it, it's formed posterior to it. It's all referring to the same thing. But to be more specific, we are acknowledging that the location of the formation, okay, is at the posterior region of the psoas major muscle. Okay, so it forms from the anterior rami of the upper four lumbar vertebrae, and the branches of the plexus emerge from the lateral, the medial, and the anterior side of the muscle. So some of those nerves emerge from the medial side, while some emerge from the lateral side of the muscle, while you can see one emerging from the anterior side of the muscle, from the anterior surface of the muscle. So it's all rallying around the psoas major muscle. It's very crucial as a relation to the lumbar plexus. So the roots are L1 to L4 normally. It's once in a while that you have contribution from the T12, the subcostal nerve. So the the nerves, the spinal nerves have different contributions. They give different branches, and this is what we mean by the contribution, such as you having the L1 giving contributions to the formation of iliohypogastric and ilioinguinal, while L2 to L4 they mix together in ways we'll explain shortly to form major branches, um, including the femoral, the obturator, amongst other branches of the plexus. And to give an overview further, you will appreciate the subcostal nerve being the T12 here, okay? But the L1 is giving rise to the iliohypogastric and then the ilioinguinal nerve. And you can see the genitofemoral nerve arising from the L1 and L2. Okay, and then you see the lateral cutaneous nerve receiving contribution from a mix of these other nerves, as we'll highlight shortly. This is what is illustrated here as well, these nerves. So the iliohypogastric nerve is arising from L1, just as the ilioinguinal is arising from L1. So you appreciate this color coding to give a better understanding of what gives rise to what. So the same L1 joins with L2 to give rise to the genitofemoral nerve, which you can see here. So it's given the same color code. Next to the lateral femoral cutaneous nerve, it's arising from L2. It receives contribution from the L2 uh, as well as the L3. So that's the lateral cutaneous nerve. Okay. While when we move on to the obturator, you see it receiving contributions from the L2, the L3, and then L4. Okay. This make up the obturator nerve. As for the femoral nerve, it's all the way from L2, L3, and then L4, right? The femoral nerve. And we mentioned already the obturator, I hope. So the obturator received from L2, L3, and L4. So we'll come to the rest as we move along. So this diagram here illustrates the roots, the trunks, and the branches of the lumbar plexus. So you take note of how the nerves emerge through and around the psoas major muscle, right? So here is the psoas major muscle, and here is the iliacus muscle. So by the time you get here, the psoas and the iliacus together are referred to as the iliopsoas muscle. So here, all the way superiorly um, is the diaphragm, the posterior part of the diaphragm, right? Having a number of openings for the esophagus, so that the esophageal opening, for the aorta, and as the aortic opening. So here is the diaphragm. The 12th rib is seen here, and then the subcostal nerve is coming. You can see it beneath the 12th rib. That's why it has that name, subcostal nerve. So inside too, you can appreciate the iliohypogastric nerve, which is the first branch of the L1, and then you have the ilioinguinal nerve. We'll talk about what each of these nerve does in just a moment. And you'll see some rami communicantes. Rami communicantes, particularly the gray rami communicantes, I'll talk about them in a number of slides to come now. And then these of course are the vertebrae, the lumbar vertebrae. So the obturator nerve is over here, and you have the lateral femoral cutaneous nerve inside too. Here you can see its relation, its path, over the ilium, over the iliacus, over the pelvic rim, to then come into the thigh. We'll come to that in a moment as well, but this is just giving an overview. Then We can see as well the trunk here, the lumbar trunk, the lumbosacral trunk over here, and then you have the sympathetic trunk. The sympathetic trunk is a string of ganglia that run down each side of the spine, throughout most of its length. It contains cell bodies of neurons that belong to the sympathetic nervous system. And what does the sympathetic nervous system do? It's the type, it's this aspect of the autonomic nervous system that functions to, as we say, the fight and flight, to increase heart rate, increase blood pressure, constrict the blood, dilate the pupils whenever one is under stress, as needing to fight and flight and take a flight. So that's what the sympathetic nervous system does. So this is a sympathetic trunk. So containing the cell bodies of the neurons that belong to the sympathetic nervous system. So these neurons project their axons to muscles and glands, all around. You see also the sciatic trunk, which will end up forming the sciatic nerve, the largest nerve in the body. And then the femoral nerve is seen right here. So here is a cut end of the psoas muscle. So on this other side, you appreciate, we mentioned the aortic opening already, and the crus. So this is the left crus of the diaphragm, and the right crus is over here. Um, yeah, we've seen the psoas muscle. Here is the genital branch of the genitofemoral nerve. So let's pause here to assess our understanding so far. So the question here is about the formation of the lumbar plexus. So which of the following spinal roots is not a primary contributor to the lumbar plexus? We need to emphasize this, right? Is it L4, the L3, L1, or T12? Right? Give your answer, and we'll be good to go. So going further, let's now discuss the branches of the lumbar plexus. There are seven of them. There are seven of them, and let's go over what each of them does. And the name actually gives it gives a hint about what the nerve is majorly responsible for. So let's start with the iliohypogastric nerve, which arises from L1. Why is it so named? Ilio is referring to the transmit sensory impulse from the skin that is over both the iliac crest and the hypogastrum. The hypogastrum is the part of the body, the part of the anterior abdominal wall that is inferior to the umbilicus. So that's the hypogastric region. Remember the nine regions of the abdominal wall or of the abdomen. So that part that is um, below the umbilicus is referred to as a hypogastrum. So the iliohypogastric nerve provides motor innervations to the abdominal muscles, and then sensory impulses. It relays sensory impulse to the skin that is over the iliac crest as well as the hypogastrum. Okay, that's why it's called the iliohypogastric nerve. And the second nerve is the ilioinguinal nerve, which provides sensory innervation to the inguinal is referring to the groin, right? So it provides sensory innervation to the groin and the anterior scrotum in males, while in females it provides sensory innervation to the labia majora. So both the iliohypogastric and ilioinguinal nerve provide nerve supply to the lower abdomen and groin. Okay. Next, the genitofemoral. This nerve has two branches. Okay, and it's those two branches, the genital branch, which supplies the cremaster muscles in males, and then the femoral branch, which is sensory to the skin. So it picks up sensory impulses and relates that back to the central nervous system. So that's the genitofemoral, and that's why it has that name. The genital. And next is the lateral femoral cutaneous. This is the one that gives sensory innervation to the lateral thigh. So the nerve is purely sensory. It has no motor component, so it supplies the lateral thigh, and the name so suggests that. Next, you have the femoral nerve proper, so arising from L2 to L4. It's the largest branch of the lumbar plexus, and remember the sciatic nerve is not a branch of the lumbar plexus, so it's more sacral in origin. So the femoral nerve is the largest branch of the lumbar plexus, providing motor innervation to the anterior thigh muscles, right? So that's why it has that name. That's the femoral region, and these are the femoral muscles. Next, you have the obturator nerve, which arises from L2 to L4. Obturator nerve, like we highlighted earlier. So the obturator nerve is medial. It provides motor innervation to the muscles you have in the medial compartments of the thigh. Okay, so this nerve is responsible for adduction of the thigh because that's the function of those muscles, and that's why those muscles have the name adductors. Adductor longus, adductor magnus, adductor brevis. So the obturator nerve serves these muscles to be able to conduct their function, their action of adduction. That's the obturator nerve. The accessory obturator nerve is usually arising from L3. It's receiving contribution from L3 and L4. It's not all the time there. So, like the name suggests, it's accessory. So whenever it's there, it's infrequent, but it's also gives support to the adductor muscles. The same thing that the obturator nerve does. So it's an accessory obturator nerve, and the muscles involved in adduction get innervated by this nerve. So with this, we appreciate the seven major branches of the lumbar plexus things, and I'm here suggesting a mnemonic that helps you to keep this in mind. Guess what influencers do? Immediately they go live, what happens to followers? They open their apps, okay? So immediately influencers go live, followers open apps. Immediately influencers go live, followers open apps. So the first I is iliohypogastric, the second I is ilioinguinal, the G is for genitofemoral, L for lateral femoral cutaneous, F for femoral nerve, O for obturator nerve, and then the accessory obturator nerve has the final A. I hope that helps. So the lumbar plexus is not just a somatic network, okay? It has the significant autonomic connections through the sympathetic nervous system. And you would appreciate here, I was talking about the anterior rami receiving rami communicants from the sympathetic. So to understand this better, you have here an illustration of a cross section of the spinal cord. So here is the spinal cord. You have the gray matter deep within, that's this H shape you can see here, while the white matter is what surrounds the gray matter. And from this gray matter, it has horns. The arms of the H, the letter H, are referred to as horns. So this is the anterior side. Remember, it's a cross section of the spinal cord. So here is anterior and here is posterior. So the horns emerging from the anterior end are referred to as the anterior horns, otherwise known as the ventral horns, while those from the posterior are referred to as the dorsal horns or the posterior horns. What comes out of the anterior horns are the anterior roots. Okay, it's referred to as the anterior root of the spinal cord, okay, at that level. So this is the anterior root, while what comes the nerve that emerges from the posterior end is referred to as the posterior root. And the anterior root usually contains motor neurons, okay, while the posterior root has the sensory neuron. So a motor neuron is a neuron that projects its axons from the central nervous system, the spinal cord in this case, to the muscles to control them, whether directly or indirectly. So that's what the motor neurons do. As for the sensory neuron, it's a neuron that transmits nerve impulses from a sense organ on the periphery of the body. It could be the eye, it could be the skin, so it could be any sense organ, and then transmits the impulse towards the central nervous system. That's typically what a sensory neuron is. So you have sensory neurons emerging from, entering the spinal cord from through the posterior root, while motor innervations come out of the central nervous system, in this case, the spinal cord, through the anterior root. So after this exit of the posterior root, you can see this little expansion here. So this is a ganglion, referred to as posterior root ganglion. So a ganglion is an encapsulated collection of nerve cell bodies that are typically connected by synapses. So they often form this kind of swelling that you're seeing here on a nerve fiber. So here is a ganglion. So a ganglion that is in the dorsal root of a spinal nerve is referred to as what? As a dorsal root ganglion. Okay, so these are backgrounds to your neuroanatomy, which you would appreciate further in the neuroanatomy lectures. So here, after you have the posterior root ganglion, so you have the ganglions and the posterior root usually. So after the ganglion is formed, then the nerve fiber continues, and then the spinal nerve is then formed at this point, where you have the anterior root meeting with the posterior root. So at this point, there is decussation. We talked about crisscrossing of the nerve fibers the other time at the beginning of the lecture, in perhaps the first slide. So this crisscrossing, you can see the blue coding for the sensory nerve fibers is meeting up with the red coding for the motor fibers. And you'll see that there are crisscrossing really, where you have at the end of this crisscrossing, you have both red and blue in the outcome in this division, and then you have red and blue in this division. So this division, the bifurcation of the spinal nerve at this point results into what we call ramus. Rami is the plural, ramus is the singular. So the posterior ramus is the one you have at the back, and that will be the sensory neuron. Okay, that's the sensory ramus or the posterior ramus, while the one emerging from the front is the anterior ramus. And we defined plexuses as a union of all the anterior rami. Okay, so posterior is not what forms plexuses. Plexuses are formed from the anterior ramus, from the anterior rami. Why? Because it's chiefly a motor activity. They are sending motor impulses, to muscles to be able to control the muscles. And we talked about the branches of the plexus, and you understand that they are going to innervate one point or the other. So that's why it's an anterior rami business, literally. Okay, so after the anterior ramus emerges, then you also encounter this interesting structure. You can see this little ball here. That's the sympathetic trunk. So the sympathetic trunk is a string of ganglia, okay, that are running down each side of the spine throughout most of its length. We mentioned it earlier. So it contains the cell bodies, and you can see it thick this way. So it contains the cell bodies of neurons that belong to that sympathetic nervous system. Yeah, so this sympathetic trunk, what does it do in this case? You can see that it has two small branches. So those are rami of their own too. Okay, and in this case, those are the rami communicantes. Right? So these are the rami communicantes we are talking about. So the one that is um, the one that uh, coordinates or that conducts. So you have gray rami here, and then you have the white rami here. And by being gray rami, first of all, the point we are trying to make is that all the anterior rami of the spinal nerve, okay, in this lumbar plexus receive gray rami. This is the anterior ramus, remember, which is contributing to the formation of the plexus. So it receives gray rami communicantes from the sympathetic trunk. So the sympathetic trunk is feeding this anterior ramus with these gray rami communicantes. And these gray rami communicantes carry postganglionic sympathetic fibers. Remember, they are coming from sympathetic trunk. So the sympathetic trunk has its mission, has its intent, has its plans. It needs something as a vehicle to go execute those plans. And those are the sympathetic fibers. So postganglionic in the sense that after they exit this ganglion. So postganglionic sympathetic fibers, which are primarily responsible for innervating those blood vessels, those sweat glands, that go to affect all the constrictions and all that, all those fibers are emanating, are contributed by the sympathetic trunk into the anterior rami that will then go into forming the plexuses and what have you to eventually innervate those muscles to be able to execute the fight and flight. Okay, so all the anterior rami receive gray rami communicantes from the sympathetic trunk. And those gray rami communicantes are the small fibers that are seen moving in this direction. And then additionally, the upper the upper two anterior rami, right? The upper two anterior rami of the lumbar plexus, typically L1 and L2, they give off white rami communicantes, right? They give out or give off white rami communicantes to the sympathetic trunk. So the sympathetic trunk give gray rami communicantes to the anterior rami, and then when it comes to now, you see the use of the sensory fibers that are contained within the plexuses. So the white rami communicantes are received back into the sympathetic trunk. So the upper two anterior rami of the lumbar plexus from L1 to L2 give they, they give off the white rami communicantes back to the sympathetic trunk. So these white rami carry preganglionic sympathetic fibers, from the spinal cord, to the sympathetic chain, which then participate in the autonomic regulation of visceral functions. So we appreciate from this image, that the interplay between the somatic and the autonomic system is quite crucial, for the integration of voluntary and involuntary control in the lumbar region. And clinically speaking, having a good understanding of these connections is very critical for managing conditions like when patients complain about referred pain, or what is diagnosed as autonomic neuropathies, or certain vascular disorders as well. Okay, so talking more about the emergence, we've talked about the formation of these nerves, of this plexus behind or posterior to the psoas major muscle, right? Now, the emergence. So the nerves emerge from the psoas muscle in three main ways, either medially, in front, or laterally, like was mentioned earlier. So the nerves that emerge from the lateral side, as you can appreciate here, include the iliohypogastric nerve, okay, and of course the ilioinguinal nerve, right? Then you have the lateral cutaneous nerve, the lateral cutaneous nerve. So that's what you see coming out here, okay, the lateral cutaneous nerve, and that is the same nerve that is coming out here. So the lateral cutaneous nerve of the thigh, or the lateral femoral cutaneous nerve, as you may please. And then lastly, the femoral nerve proper itself. So that's the largest branch of the of the lumbar plexus. So the femoral nerve proper, that's it here. So from the medial side, however, it's majorly the obturator nerve, right? Arising from L2 to L4. So this emerges from the medial side of the psoas major muscle and travels into the pelvis, to reach the obturator canal and then innervate other structures like we covered during the pelvic region. So you also have what applies to the obturator, the accessory obturator nerve whenever it's present, which arises majorly from just L3 and L4, right? So it's a less consistent nerve. It also emerges medially and descends to join the obturator nerve or supply nearby muscles directly. So then from the anterior surface, you have the genitofemoral nerve arising. So in summary, on the lateral side of the psoas major, you have the iliohypogastric, ilioinguinal, the lateral femoral cutaneous, and the femoral nerve itself arising from the lateral side. While from the anterior surface, you have the genitofemoral, and then from the medial side, you have the obturator nerve and the accessory obturator nerve whenever it's present. So this pattern of emergence is clinically significant as well, especially in surgeries that involve retroperitoneal space or during pelvic procedures where the nerves may be at risk of injury. So it's important to know what is expected to be found on the lateral side of the psoas major, on the anterior, and on the medial side. Okay, so the iliohypogastric and ilioinguinal nerves enter after they arise from the lateral side of the psoas major muscle. They go ahead to enter the lateral and anterior abdominal walls, and eventually the iliohypogastric nerve uh, further, supplies the skin of the lower part of the anterior abdominal wall, that region that is known as the hypogastrum, and that's why it has that name, iliohypogastric nerve. So this is the region known as the hypogastrum, and here is the anterior cutaneous branch of the iliohypogastric nerve. And the ilioinguinal nerve, on the other hand, you can see it um, supplying the skin of the groin and the scrotum. So in males, but if it were a female, it's going to be supplying the labium majus or labia majora. So it passes through the inguinal canal to achieve this supply. So next is the genitofemoral nerve, which arises from L1 and L2, which receives contribution from the L1 and L2. So it emerges from the anterior surface of the psoas major, like we mentioned earlier, and the genitofemoral nerve thereafter runs downward in front of the psoas major muscle, from which it arose, and then divides into two. So it gives off a genital branch, okay, which goes on to supply the cremaster muscle, like mentioned, and then it gives off a femoral branch. Okay, so the genital branch enters the spermatic cord and supplies the cremaster muscle. So in the nervous pathway involved in the cremasteric reflex, in which stimulation of the skin of the thigh in male results in the reflex contraction of the cremaster muscle and the drawing upward of the testes within the scrotum. So whenever this branch is severed or paralyzed or injured or damaged, then such an individual will not be able to effect the cremasteric reflex, okay, in which the stimulation of that skin of the thigh will make reflect, result into a reflex contraction of the cremasteric muscle or the testis of the scrotum. As for the femoral branch, it supplies a small area of the skin in front of the thigh. Okay, so that's the femoral um, that's the femoral branch of the genitofemoral nerve. It supplies a small area of the skin. So it's expected that when there is damage to that muscle, to that nerve, the individual will not be able to feel sensation in that region of the thigh. Next is the lateral cutaneous nerve, lateral femoral cutaneous nerve, or lateral cutaneous nerve of the thigh. So this crosses the iliac fossa, right? As it emerges, so it crosses the iliac fossa. You can see the iliacus muscle here. So the lateral cutaneous femoral nerve crosses the iliac fossa in front of the iliacus muscle and then enters the thigh behind the lateral end of the inguinal ligaments, which you can see here. So this is quite close to the anterior superior iliac spine, the ASIs. And thereafter, the nerve supplies the skin that is over the lateral surface of the thigh, and hence the name lateral cutaneous nerve of the thigh. So here is the nerve here, and here is the part where it innervates. Next is the femoral nerve, which is the largest branch of the lumbar plexus. So right here, it runs down and laterally between the psoas and the iliacus muscle before entering the thigh behind the inguinal ligament, lateral to the femoral vessels and the femoral sheath. So it supplies the iliacus muscle on its way. Okay, it supplies the iliacus muscle in the abdomen. Um, so next is the obturator nerve and the fourth lumbar root of the lumbosacral trunk, which both of which emerge from the medial border of the psoas at the brim of the pelvis. Next is the obturator nerve, and this nerve, which you can see here, so it's together with the fourth lumbar root of the lumbosacral trunk emerge from the medial border of the psoas muscle, as we mentioned earlier. So at the brim of the pelvis. So that's the obturator nerve there. Um, so it crosses thereafter. It crosses the pelvic brim in front of the sacroiliac joint behind the common iliac vessels, and it leaves the pelvis by passing through the obturator foramen into the thigh, where it supplies the abductor muscles. So the fourth lumbar root of the lumbosacral trunk unites with the L5 and takes part in the formation of the sacral plexus, and it descends anterior to the ala of the sacrum to join the first sacral nerve. So the accessory obturator nerve, whenever it's present, also takes a similar route to the obturator nerve. So once again, the branches of the lumbar plexus, the iliohypogastric, the ilioinguinal, the genitofemoral, right? The lateral femoral cutaneous, the obturator, and then the accessory obturator. The femoral nerve, we mentioned that, and then the obturator, and then the accessory obturator. Don't forget, immediately influencers go live, followers open arms. That should be helpful. So let's pause to test how far we have been coming. The obturator nerve is derived from which spinal root? Obturator nerve is derived from which spinal root? The answer here at all? So you may tell me. Um, so this is an additional slide that shows the pathway of each nerves, and you pay particular attention to the relationship of all these nerves, the psoas muscle and the inguinal ligament. So this relationship is very crucial for understanding nerve entrapment syndrome. For example, the lateral cutaneous femoral nerve or the lateral femoral cutaneous nerve um, under the passing under the inguinal ligaments. So this, the way it passes, you can see it's quite close to the anterior superior iliac spine as earlier mentioned. So this makes it very prone to compression in conditions like obesity or when somebody wears a tight clothing. So this, whenever it gets entrapped, then an individual would naturally feel pain around that area. Also, the genitofemoral nerve may be compressed during abdominal surgeries too. And um, yeah, so in the case of the lateral femoral cutaneous nerve, whenever it's entrapped, it results into neuralgia paresthetica, which is a numbness or pain in the lateral thigh, the lateral part of the thigh that is caused by lesion to the lateral cutaneous nerve of the thigh. In this regard, it's from the root word, it's a merger of two Latin words actually. So you could interpret it as thigh pain with anomalous perception. So thigh pain is the neuralgia, neuro is the thigh, algia is pain, so thigh pain. So paresthesia is an anomalous perception, the feeling of numbness. So that's paresthetica, neuralgia paresthetica. And now let's connect the branches of the lumbar plexus with their motor and sensory functions. The femoral nerve powers the quadriceps. The femoral nerve powers the quadriceps for knee extension, and the obturator nerve controls the abductor muscles. I mentioned that already. So here is the domain of the obturator nerve, the medial thigh for abduction, and the anterior thigh is the concentration of the femoral nerve. Okay, while the femoral branch of the genitofemoral nerve is what gives this cutaneous sensation at this upper part of the anterior thigh. Okay, while for sensory, the lateral femoral cutaneous nerve supplies the lateral thigh. Okay, supplies the lateral thigh, while the femoral nerve supplies the anterior thigh and medial leg. So um, yeah, so the omission of other branches is simply in this list is simply because they have specialized roles of the mentioned nerves. So the femoral nerve, the obturator nerve are the primary motor and sensory nerves of the lumbar plexus with significant contributions to large, functionally important regions, the anterior and medial thigh. So other branches like the iliohypogastric, ilioinguinal, the genitofemoral, they have more localized and less significant motor and sensory roles that are often associated with the lower abdominal wall, the groin, the external genitalia, rather than the thigh. So that's just why the major emphasis is on this. So um yeah, the lumbar plexus of course is clinically important. It's an additional point. So when there is an injury to the femoral nerve, there is such individual will not be able to extend the knee because the femoral nerve is supplying the quadriceps muscles of the thigh, of the anterior thigh, and paralysis to that nerve would also diminish the patellar reflex. That's because whenever the the patella is um, whenever the patellar impulse is delivered, so that is the reflex is affected by the tendon of the quadriceps muscles, right, which is innervated by the femoral nerve. Also, where there is an injury to the obturator nerve, like you understand that abduction is the main function of the nerves, the the muscles that are innervated by the obturator nerve, the adductor muscles. So there will be weakness in thigh adduction for such an individual. And then we talked already about neuralgia paresthetica, which is arising with numbness or pain in the lateral thigh or in the thigh region, so particularly due to compression of the lateral femoral continuous. A patient presents with loss of knee extension and absent patellar reflex. So, which nerve is most likely involved? Is it the obturator nerve, the femoral nerve, the sciatic nerve, or the genitofemoral nerve? Your answer appropriately. Also, the next question is asking what is the case with a 35-year-old patient that undergoes pelvic surgery and postoperatively develops a difficulty in extending their knee, and then they also have a diminished patellar reflex, which nerve is most likely injured? Which of these nerves is it? Next, the fifth question is about a 45-year-old male that is obese. So he is obese and he complains of numbness and tingling sensation over the lateral aspect of the thigh. He reports wearing a tight belt recently. Okay, so what is the likely diagnosis? What's the likely diagnosis? Is it sciatica? Is it neuralgia paresthetica? Is it femoral nerve compression? Or is it obturator nerve entrapment? The sixth question is asking for the root. What's the root? What are the spinal roots of the lateral femoral cutaneous nerve? And the seventh question, which branch of the lumbar plexus supplies the abductor muscles of the thigh? Is it the femoral, the obturator, the genitofemoral, or the lateral femoral cutaneous nerve? Then the final set of questions, question 8, the femoral nerve supplies which group of muscles? The anterior, posterior, medial, or lateral thigh? The ninth question, compression of which nerve causes neuralgia paresthetica? The femoral nerve, the lateral femoral cutaneous, the obturator, or the genitofemoral nerve. And lastly, a patient with difficulty in abducting their thigh likely has an injury to which nerve from the ones listed here? So the femoral, the obturator, the lateral femoral, or the genitofemoral nerve. So to summarize, we have appreciated in this lecture the formation of the lumbar plexus as being from the anterior rami of L1 to L4 and with contributions once in a while due to some anatomical variations from the T12 nerve. And then the major branches, we explained that the lumbar plexus major branches include those 7 that we know: immediately influencers rule life, followers open arms. You know what that means. And lastly, we've gone through a number of clinical nerve injuries that can result in significant motor and sensory deficits. So that's it for today's lecture. I'm happy to see you engaging, and I'll be looking forward to your comments with the correct answers to all of the MCQs. Remember, the first set of students to do that will receive a shout out in the next video. So don't delay, get your answers in as soon as you can. And until next time, stay curious and keep learning. All the very best, and see you at the next instance. Bye.